My name is Maddie, and I'm here today to talk about how we can address mental health in teens with FASD, and really touching on a lot of Jacob's great points on building really accessible and community-informed treatment approaches. As we know, 90% of individuals with FASD experience some type of mental health challenge in their life. This is especially pertinent for teens, as 35% of teens report suicide ideation, and 13% report at least one serious suicide attempt within a year. This is in stark contrast to the general population, with 17% of teens experience ideation and 2% attempting suicide within a year. We know that people with FASD's brains can work a little differently, and this is one key reason that we may be seeing these increased rates of mental health challenges. In people with FASD, we see differences in the amygdala, which we can think of as our alarm system. This is what detects threats in our environment and triggers really big emotion reactions. We also see differences in what we call the prefrontal cortex, which is our control center. This helps with things like decision-making and starting and stopping our natural impulses. When these two systems are working together, the amygdala alerts us to something in our environment, and the prefrontal cortex helps to control that emotional reaction. However, this looks a little bit different in teens with FASD, where we see that the alarm system is a little bit louder, and the prefrontal cortex has a harder time controlling that emotion. We then layer on top of this higher rates of adversity and traumatic experiences for people with FASD, as well as adolescence being a really high-risk period for mental health challenges. It does make sense why we're seeing these increased rates. While the literature has shown us that the mental health crisis exists for teens with FASD, we still have two core problems to address. First, there are no evidence-based mental health interventions adapted or made specifically for teens with FASD. And two, we are then asking teens with FASD to succeed in treatments that were not designed for them. So I would like to propose a possible solution to this: a guide for adapting mental health interventions that is FASD-informed, evidence-based, and accessible. I'm going to be walking through the steps of this guide by using an example of how I took an evidence-based mental health intervention called dialectical behavior therapy, or DBT, and adapted it for teens with FASD. The first step in our guide is to first and foremost look to the community to define the problem. The FASD community has identified mental health as a primary challenge, just as we heard Jacob speak of today. And we want to couple this community-identified need with theory and research. So one of the most evidence-backed mental health treatments for individuals with high rates of emotion dysregulation, suicidality, and interpersonal challenges is called dialectical behavior therapy, or DBT. Leading scholars in the field of FASD intervention have pointed to DBT specifically as a treatment needing further research for this population, given its emphasis on skill building in areas that people with FASD often require extra assistance on, and given that many clinicians are already using this intervention with teens in everyday practice. This is not surprising, given the overlap between the experiences individuals with FASD face and the model in which DBT is based upon. So what DBT theorizes is that biological vulnerability, coupled with different invalidating environments, leads to an increased risk of emotion dysregulation. So let's start by mapping this onto FASD. We just briefly talked about the brain-based differences that are associated with the impact of prenatal alcohol exposure. We then look at all the invalidating environments a teen with FASD may experience, whether that be disability stigma, lack of access to supports and services, lack of knowledge on FASD by providers that are working with them, multiple home transitions, people misinterpreting their behavior as willful, and the trauma experiences I briefly touched on earlier. We add on top of this all the other invalidating environments that any teen encounters, and that leads to severe emotion dysregulation. DBT's aim is to address this dysregulation with the end goal of helping teens to build a life worth living. It does so through teaching skills in 5 main areas. So we have mindfulness, distress tolerance, interpersonal effectiveness, something called walking the middle path, which is kind of a fancy way of saying finding a balance between 2 extremes. So an example of this in the adapted program is balancing I'm a teen and I want to be independent with I'm a person with FASD and I may need some extra supports at this time. And then lastly, they learn about skills related to emotion regulation. And this is accomplished through weekly skills groups, where both teens and actually their caregivers as well attend sessions to learn about these skills so that the caregiver can assist the teen in implementing these skills in everyday life. There's also individual therapy sessions where the teen is meeting one-on-one with a DBT clinician. Family members can also join into these sessions as well as if a family session is warranted. And teens and their caregivers also have access to 24/7 phone coaching. So if a teen is in a crisis and they are unable to utilize their skills, they can actually call up a DBT therapist and that therapist will walk them through how to utilize those skills. A systematic review that is currently in progress has demonstrated that DBT is showing a lot of promise in other neurodiverse populations, ranging from autistic individuals to people with ADHD, intellectual disability, learning disability. And the key here is it's showing promise if it is adapted. While this is not an extensive literature, the adaptations so far have included simplified language, slower pacing, increased repetition, visual and concrete supports, and additional caregiver supports. Given the need in the prior research, we therefore sought out to develop and test a DBT program made for teens with FASD specifically. The next few steps in our adaptation guide included a needs assessment, where we asked the community if DBT was a good fit and what changes we could make. The next step was to create new materials based on community input that is also backed by theory and evidence. We use a rigorous implementation science framework for this, which in the sake of time I won't go into, but I'm happy to answer questions about later. Then when we create it, we want input from the community as well on those created aspects, and then we want to test it in a real-world setting, and after testing, further get some of that community input so we can refine and disseminate the program. So, our first step, we asked about the overall fit of DBT for the needs of individuals with FASD. We surveyed both teens and their caregivers who watched short videos that explained what DBT was and gave a little bit of an explanation on the different DBT skills. The teens and the caregivers then answered questions about how helpful each of these skills seemed, how hard or easy they may be, and then gave us ideas on how we could change them and make them more accessible. Caregivers also shared additional details on what might make it easier or harder for their family to participate in a program like this because it is so intensive of a treatment. We also wanted to survey DBT clinicians nationwide, and we assessed for their prior training in FASD, their experience working with neurodivergent clients in DBT, and what their training needs and interests might be if they were to use this adapted program. They also identified what needed to be adapted based on their prior experience with neurodivergent individuals and what barriers and facilitators to implementation they may foresee. And what we found was that teens and caregivers gave us really great insight into the fit of DBT. They said that they thought it would be great for fitting the needs of what their teen needed at that time. They also showed us what skills were the most challenging and the most helpful for their teens, and then gave concrete suggestions on how we could modify each of these skills. Clinicians also gave insight into their training needs on FASD, any clinic structure barriers or facilitators that may get in the way or help in implementing a program like this, and any past DBT work they had done with neurodivergent folks. So once we had all that rich data from our needs assessment, we moved to the creation of this program, which is step 2. In doing so, we really wanted to make sure we were balancing both fidelity and accessibility. And to do this, we did use another implementation science framework that I'm happy to answer questions on later as well. But the main goal here was to maintain the core parts of DBT while also making sure that this intervention was accessible. I also consulted with a group of experts in the field of FASD intervention, a few of whom are in the room today, implementation science, and DBT research and clinical work. And of course, I also made sure my materials were reviewed by teens with FASD and adaptations were made based on the feedback that they gave me. So what exactly did we end up creating? So for clinicians, we created a 250-page manual that includes information on FASD, how FASD may impact the uptake and or understanding of these various DBT skills, as well as gave language for clinicians to use that would make the explanations of those skills more accessible for teens with FASD. We did adapt a comprehensive program, and this manual can be utilized by clinicians as a full comprehensive modification to true DBT. There's a lot of reasons why we did this, but first and foremost, DBT was not made for people who learn differently. As I mentioned, we adapted all parts of the program, so we wanted to make sure the manual covered all of them. And we know that concepts can be confusing without concrete explanations and examples for teens, so we wanted to make sure that these clinicians understood how to teach these skills. We also created a two-part training for clinicians. So the first part was an intro to FASD. What does FASD look like? What does FASD look like in a therapy room? And how can we be a neurodivergent affirming clinician? The second training focused on how they could take the adapted program and implement it into their clinic. And the reasons we did that is our needs assessment found that clinicians have little to no training on FASD, and it's really hard to teach DBT for FASD if you don't understand how FASD can impact learning. And then they also noted that clinicians did need some extra support in adapting in the moment. For teens with FASD and their caregivers, what did we make? So we adapted all the introductory materials to DBT. So before individuals enter their skills groups, they go through what's called pre-treatment, where they learn and understand kind of what they're getting themselves into. We wanted to make sure these materials were easier to understand. We also created adapted group skill slides. So to make sure teens had both visual and auditory options for learning, a slide deck for each week of skills was created that included visual schedules, simpler text, eye-catching colors, and images that were not too overwhelming, and relevant examples for teens with FASD. We also created a workbook for teens and caregivers that included simplified descriptions with visuals of each week's lesson that they could review on their own time, along with simplified homework materials and the completed homework next to it in case teens wanted to follow along. And lastly, I won't get too much into this, but we adapted all the individual materials as well. This is an example of a diary card, which is used daily in this program, where teens can track different behaviors that they want to work on, their emotions, and whether they use their DBT skills. There are a lot of major themes behind all of the modifications we made, and I'm going to start by explaining what inspired the change, or the why, and then how we applied it, or the what. So we know that big and abstract words can be challenging for teens with FASD, so we made sure there was simpler language and visuals involved. We know that attention spans can be shorter. Some of these group sessions were an hour and a half long. That's really long for anybody. So we wanted to make sure more breaks were incorporated, more structured breaks, movement breaks. We also know memory challenges can impact teens with FASD, so we included more repetition. At the start of every session, we reviewed last week's session. At the end of every session, we reviewed everything we learned that day. And then at the end of every module, there was a whole session dedicated to review of the entire module. We also know processing speed can be a little bit challenging, so we worked with clinicians on slowing down their pacing throughout the program. We also know abstract ideas or metaphors can be confusing, so every example given was very concrete. And we know that predictability can really help with learning. So we had consistent structures, we had visual schedules, every week looked very consistent. And we also we know too much information at one time can be overwhelming for teens with FASD. So we made smaller chunks of information. Traditional DBT gives 2 to 3 skills a week. We made sure that was only 1 to 2 skills. So now that we've created it, we move to our next step. We want to test the program that we created. So we did a single-arm mixed methods feasibility trial. We had 8 teens with FASD and their caregivers enter into the program, so that is 2 different cohorts of DBT. And we also had 5 DBT clinicians who are participating. This took place at an outpatient comprehensive DBT clinic that was led by a DBT Linehan certified clinician. The intervention took about 30 weeks, bookended by 2 research visits where we assessed teens and parents' emotion regulation, internalizing and externalizing behaviors, and then everyone went through an exit interview to tell us what they thought about the program. We had 4 aims. First, feasibility. Is this something that we can even do? We then moved into fidelity. Can we stick to DBT as it was intended to be delivered? Acceptability. Did people end up liking it? And last but not least, which is not super traditional of a feasibility trial, but we did want to see if there was any preliminary clinical efficacy. So that's just a fancy way of saying, did the program actually work? So I'm going to start with, can we do this and can we stick to DBT? The short answer is yes. We had an 87% completion rate, an 85% attendance rate, an 85% engagement rate, which is on par or better with other DBT trials, as 60 to 75% complete treatment in typical DBT, with attendance rates typically between 75 and 85%. DBT naturally has a higher dropout rate, just given how intense it is and the symptom presentations that you can see. We also measured if clinicians were maintaining fidelity to treatment. So were they sticking to DBT as it was intended? We recorded and coded individual sessions based on the DBT adherence checklist, and this checklist measures adherence to the modality as getting 24 points. I'm happy to answer questions about what that looks like later. And our mean came in around 23.89, so if we just round up, our clinicians did great. They stuck to DBT. And during our interviews with clinicians, we saw similar results. They stated it flowed right into the structure of how they usually do things. It was helpful. They already had comprehensive DBT, and it felt like they were just following the rules of DBT as it was intended, which is great. That's exactly what we wanted. We then move into, did people like it? I'll start with the yes, and then we'll get into the no. But the yes, we had teens who are in the light green, caregivers in the dark green, and clinicians who are in the gray, who filled out a questionnaire about various aspects of acceptability on the program. So I've pulled out here what was rated the highest and what was rated the lowest by our groups. So our highest means were in acceptability, so was the program acceptable? Did it fit the needs of teens with FASD, with our teens actually recording that as the highest? Was it effective? That's another way of saying, did it work? Teens also rated this the highest as well. And was it understandable? Our lowest mean was in burden, so was the DBT program a burden to you? And that's the one that we want the lowest, so that was great. And we also saw that this came out in our interviews as well, with a caregiver stating that they really liked it because it was actually geared toward FASD and other mental health treatments are not. And teens also really saying that they liked it. They really liked their therapist. They thought their therapist understood their needs. So even though we found the program to be acceptable and feasible, participants across groups gave really clear guidance on how we could go about improving it. So teens wanted shorter sessions, more hands-on activities, and clearer tools, while caregivers wanted clinicians to practice the skills with their teen outside of the therapy room. They wanted additional concrete examples given, and they wanted a caregiver-specific support group. Clinicians wanted more training on FASD-specific behaviors. I actually ended up going in mid-trial and giving a training on confabulation was one they wanted more understanding of. And then they wanted ongoing consultation support as well. Now we move into, did it help? I'm gonna go with yes question mark. Again, this is preliminary. We're looking at 8 teens and 8 caregivers here, so keep that in mind as I walk through this. But we did see that every teen showed reliable change in at least one domain. We saw improvements in anxiety, depression, behavioral challenges, attention, and overall social functioning. And to calculate this, we used what's called a reliable change index. So we know that every survey or test that we give out has a little bit of noise or error within it. And this reliable change index helps us to figure out whether that change we see in scores is big enough that it's actual clinical change versus not just chance or test inconsistency. Something like this is really especially helpful in smaller samples where we can't necessarily look at effect sizes, but on an individual level, did we see meaningful change? And the answer here was yes, we saw meaningful change on multiple measures. We saw very similar things in our exit interviews. So we had a caregiver report, my daughter made more progress in 6 months than she did in 3 years with her other therapy. One teen reported, "It helped me. It gave me an idea of how to be more calm." And another teen stating, "I really think it helped me have another perspective on my mom. I think it was helpful for us to get a better relationship and just be able to be a better person overall. I feel like it really helped." So overall, this program did have a great impact on teens with FASD and their families to the extent that we can show within a feasibility trial. The current study that I just walked through can serve as a model for how evidence-based practices in mental health treatment can be adapted to fit the needs of the community. I'm going to present a research-driven model, and also I'll have up on the screen a clinician-driven model to parallel it as well. So we started with co-defining the problem. We know that teens with FASD have stated mental health is a challenge for them. We then present a solution, which in our case was DBT, and we did a multi-informant needs assessment, meaning that yes, we asked teens with FASD if this is what they needed, but we also asked the other players. So we asked the caregivers, we asked the clinicians. We then make sure we ground any adaptation we make from that feedback in living experience and in theory. We use systematic adaptation designs to do so, and like I've been alluding to, we did use an implementation framework known as EPIS, which, while it does focus on adapting the intervention itself, also takes into consideration many external factors that could influence implementation. One of which is the workforce. So we also want to prepare the workforce we are working with. We develop trainings on our adapted DBT program, as well as trainings on how to work with teens with FASD in the therapy space. Once the workforce is prepared, we then want to make sure we are testing it, and we want to test it with feedback from the community. We did this through a real-world setting and not a research lab so that we could better understand what will work and what won't, and then we want to make sure we ask for feedback on that via interviews. So then we move to the stage that we are now, continuous refinement and planning for larger testing so that it can be disseminated. Which brings me to the next point. Is the manual available? It is not yet available, but it is coming soon. So my email will be on the last slide if you are curious on getting your hands on it in the future. So we just went over the research-driven model on the left, and in the middle there we have what we are calling our clinician-driven model. We are aware, and now I have become very aware, of how many years a research-driven model can take to see through to fruition. And boots-on-the-ground clinicians are needing information like this more readily. So while we have tested this research model, we have not tested the clinician-driven model, but if you would like to see either in a little bit more detail, this QR code will link you to a box folder that explains both of them. Also within this box folder are information and videos on different DBT skills, me explaining the skills. I will caveat they are not yet the adapted skills, but if you are a person with FASD who would like to learn a little bit more about what DBT is or what you could learn in a program like this, there's videos of me explaining them as well. So in conclusion, mental health needs in FASD are real and urgent. Fit for people with FASD matters just as much as the treatment itself does. Our adapted DBTA program is feasible, accessible, and promising. And the process matters. We want to be building with the FASD community. Teens with FASD don't necessarily need different goals. They need different pathways to get there. This work shows that when we design interventions with the community and adapt them for how people actually learn, we can improve engagement, accessibility, and ultimately mental health outcomes for individuals with FASD. And I did not do this project on my own. I have many thanks to give out right now. So this top row is my fantastic research lab, my advisor, Dr. Christy Petrenko, fellow graduate students, Emily Spybrook and Alicia Richardson, my clinical supervisors, Dr. Julianne Myers and Lynn Cole. And this bottom row here is my fantastic F31 consultant team who were with me at every step of the way of the adaptation of this program. Doctors Heather Carmichael-Olson, Molly Adrian, Evelyn Lynch, Jackie Pye, and Kate Cerulli. Special thank you to NIAAA, who have funded my F31 and dissertation work, Genesee Valley Psychology, who ran this program, and last but not least, especially to the teens with FASD and their families who made this work possible. Thank you.